patients. So his work focuses on early recognition and prediction of fungal infection in ICU settings and improving patients' outcomes through timely diagnostics and management. So his talk today is entitled How to Predict Invasive Fungal Infections in Intensive Care Unit. So Dr. Nikolić, the floor is yours.
Thank you very much for the kind introduction. Dear colleagues, good morning. First, I would like to thank Professor Arsenijević for the kind invitation. Today, I would like to discuss how to predict invasive fungal infections in intensive care units. Rather than focusing just on microbiological detection, I would like to explore how intensive care interventions themselves create conditions that facilitate fungal colonization, persistence, and later invasive infections. The main question is not candidates better present, but why intensive care patients and critically ill patients become susceptible to transition from colonization to infection. This doesn't work, so it's okay. Better with the mouse. Okay. On start, I would like to say that invasive fungal infections represent a significant cause of morbidity and mortality in intensive care units, as you see here on the slide, but I would like to emphasize that every delay in the introduction of adequate therapy longer than 48 hours significantly increase mortality. So time to treatment is key prognostic factor. Understanding current epidemiological trends is crucial and essential because local epidemiology directly influences our diagnostic approach, our choice of empirical therapy, and later antifungal stewardship. So, as we know, Candida remains the significant cause of invasive fungal infections in ICU, accounting approximately 70 to 90%. But we have seen in the last decade some changes in trends concerning invasive aspergillosis. So in the last decades, invasive aspergillosis is no longer linked only to hematological or deeply immunocompromised patients. It's also noticed that there are some ICU-related invasive aspergillosis, especially on viral ARDS. Viral ARDS caused by COVID-19 viruses or influenza viruses. I won't talk about mucormycosis, but it's rare and it has a great mortality. Developing invasive fungal infection is multifactorial and it's the result of interaction between host-related factors, exposures in ICU or ICU-related factors, and underlying disease. So talking about patient risk factors, we are mainly talking about neutropenia, malignancy, or previous organ transplantation. Exposures in ICU are relevant. I will talk about that in more details later, but now it's use of more than 2 antibiotics, CVC, total parenteral nutrition, and of course, mechanical ventilation. So underlying disease, we have noticed, and there are some notes that some diagnoses, such as acute pancreatitis, are linked with invasive fungal infections more than other diagnoses. Also, extensive surgery, especially extensive abdominal surgery, burns and trauma also represent significant risk factors. About metabolic factors, it's mostly poorly controlled diabetes. So the question is, why should intensivist care? Well, because invasive fungal infections remains associated with high mortality. Their colonization frequently precedes invasive fungal infections and invasive candidiasis. Critically, illness profoundly alters host immunity and barriers integrity, and every delay in diagnosis and delay in antifungal therapy is linked to higher mortality. So what are these normal host barriers? It's mostly skin and mucosal surfaces. Skin and mucosal surfaces acts both as physical and immunological barriers. So skin provides mechanical barrier. There are some resident microbiome competition, antimicrobial peptides, and also skin prevents microbial translocation. Speaking of mucosal surfaces, there are some oral cavity protection, respiratory epithelium, gastrointestinal tract, and mucosal clearance and secretory immunity. So, Candida in normal healthy organisms or in healthy conditions is commensal organisms, but the disruption of these barriers and disruption of immune system significantly increase risk for invasive infection. Critical illness and patients in intensive care units, there are chances to develop sepsis, or we treat patients with sepsis. So sepsis is a state where our immunological forces are strongly disrupted. So in sepsis, we see sepsis-induced immunoparalysis, altered neutrophil and monocyte functions, also cytokine dysregulation and lymphocyte exhaustion and apoptosis. I would like to say, pointer is working. So there are some additional ICU-related factors, such as patients in ICU sometimes on total parenteral nutrition, so there are chances for hyperglycemia, malnutrition after some surgeries, organ dysfunction. Also, patients in ICU requires use of vasopressors. So we see vasopressor-induced hypoperfusion and hypoperfusion ischemic lesion. Also, patients in intensive care units sometimes requires use of renal replacement therapy and massive transfusions. These are all factors that compromise our immunological state. As you know, patients in intensive care units sometimes require mechanical ventilation. No matter what's the cause of respiratory failure, act of intubation disrupts oropharyngeal mucosa. Just that act. Also, endotracheal tube is plastic, so it serves to form biofilm formation and later worsen therapy. Also, impaired mucociliary clearance and microaspiration around the cuff also are the factors for translocation of fungus. What else? Broad spectrum antibiotic use, sedation, and sometimes these patients that are on mechanical ventilation need to be sedated, sometimes use of muscular relaxation. So sedation reduce cough reflex, and also prolonged mechanical ventilation also are with high risk. As mechanical ventilation and intubation in intensive care units, there are some vascular access. Mostly we use central venous catheters, but it's not whether catheter is present, but which is site of the placement of central venous catheter. Also, how many lumens this catheter has. So it's noticed, and a lot of works there are for femoral insertion site as place for higher microbial burden and translocation of fungus. Use of more than 2 lumens increase frequent catheter manipulation and increases chances. Why is this important? Because in antifungal stewardship, we need to remove these catheters when we don't need them anymore. Gastrointestinal tract serve as, as reservoir for Candida, but in healthy individuals, as I said previously, that is not the problem. The problem is shock states and states of hypoperfusion, because we see there ischemic reperfusion injury and systemic inflammation. It's all the states that represent fungal translocation, fungal persistent colonization, and increased risk of candidemia. So that's the question. When does colonization become invasive disease? There are some clinical signs, clinical warnings, but there is no specific sign. That's the major problem in fungal infections and invasive fungal infections. In ICU, when we see persistent sepsis despite antibiotic use, recurrent unexplained fever, multifocal candida colonization, patient that use total parenteral nutrition, patient after abdominal surgery or anastomotic leak, or patient with severe pancreatitis. As I mentioned before, renal replacement therapy also become the state when colonization becomes invasive disease, and also prolonged ICU stay is also a risk factor. So how does it go? It goes from colonization to biofilm formation, then later biofilm disruption and bloodstream invasion and organ dysfunction. As I said, clinical presentation is a major problem in practice because there is no specific sign. But we always suspect there is some fungal infection in ICU when we see persistent fever despite antibiotics, sepsis without clear focus, hemodynamic instability, and new marks on CT scans on radiography of the pulmonary. Why prediction matters in ICU? So we see that there are no specific clinical signs, there are no specific symptoms. So we need to use some predictions, we need to use some scores, we need to use some indexes, biomarkers, etc. So invasive fungal infections, as I said, are associated with high ICU mortality. Clinical presentation is often non-specific. Blood cultures have limited sensibility and delayed positivity. Also, this delay in antifungal therapy worsen outcomes, and excessive therapy, it's very important that excessive therapy contributes to resistance and toxicity. So early risk stratification is essential. A lot of clinicians have heard, of course, about this colonization index, corrected colonization index, and candida score. All of these indexes and scores use simple numeric scale to assess patients with high risk for developing invasive fungal infections. Their clinical utility, because they support early risk stratification, may guide preemptive therapy and help us identify patients requiring closer surveillance. But important limitation, as you know, is no scoring system replace clinical judgment. After this course, we also use this candida score that use surgery, total parenteral nutrition, sepsis, and colonization for it serves as a simple bedside tool for risk stratification. There are some points, 1, 2, that score more than 2.5 stratificates patients with high risk for invasive fungal infection. Other are colonization index that use number of colonized sites. There are some Ostrowski's rule that use multiple ICU risk factors for early identification, but it's complex a little bit. And I would like to say that this biomarker-based approach is very helpful in practical conditions. So use of BDG, PCR, T2 candida used for early detection, but it's not available in every hospital and it costs a little bit much. So what are screening strategies for patients? There are culture-based screening and non-culture-based screening. This culture-based screening use oral swabs, rectal swabs, perineal swabs, respiratory samples, urine samples, and of course multiple site cultures from the patient. Non-culture-based methods combine this before said, BDG, PCR-based diagnosis, T2 candida, Menon, anti-Menon tests. This role of biomarker is very important, but as I said, they cost a little bit. They are not available in every hospital, but they help us for early detection, then blood culture, identification of high-risk patients, support preemptive therapy when we use it already, and they have excellent negative predictive value. We use BDG and galactomannan in our hospital, but our hospital doesn't have their own mechanism to do it, so we have contract with the Clinical Center of Serbia. So all of these risk scores indexes, methods have their limitation. No prediction model has adequate positive predictive value, and no one is enough and sufficient. There are risks of overtreatment, merge of antifungal resistance, and there are also increasing incidence of non-albicans candida species as we see it in our hospital. Biomarkers are not universally available, and of course, clinical judgment remains essential. After all of this talking, we need to do something in practice. So when to screen? How we do that? It's simple when I see it like this, but in practice it's a little bit complicated. First, we use these scores, candida scores, to identify high-risk patients that are at immunosuppression. We use broad-spectrum antibiotics longer than 7 days, patients with TPN. Also, we obtain baseline BDG. When we see that they are in high risk, we are adding targeted testing. And of course, when the results come, we interpret and act. And after all of this, of course, we have everyday ICU dilemmas. What should we do when we have candida in tracheal aspirant? What should we do when we have candida in urine? There are some positive results, but patient is clinically stable, his biomarkers are negative, CRP and PCT are normal. So what should we do? We don't treat that patients, but we, when we see a worsen of their clinical state, we do that again. We use BDG and other testings. So we remove catheters when it's the right timing and when we don't use it anymore. What are stewardship considerations? We need to avoid unnecessary antifungal exposure, reduce selection pressure, and prevent emergence of resistant candida species. So microbiological findings always must be interpreted with ICU clinical context. So what are take-home messages? Invasive fungal infections in ICU are related with high mortality. Early recognition is more important than delayed defined diagnosis. Colonization combined with host factors drives risk. Biomarkers, as I said, improve early prediction. And of course, best results are achieved using combination of these scores and clinical and laboratory assessment. Thank you for your attention.
So thank you, Dr. For your nice overview presentation. So we move now on to our third speaker, Dr. Marija Stošić is also an anesthesiologist at the Clinic for Cardiac Surgery, University Center Niš, and a teaching assistant at the Faculty of Medicine, University of Niš. She is actively involved in the treatment of critically ill patients in the intensive care units, with a special focus on bacterial and invasive fungal infections. Her clinical and academic work is dedicated to improving the diagnosis, individualized management, and outcome of patients with severe infections complications in the intensive care units. So her talk today is entitled Personalization in the Diagnosis and Management of Invasive Fungal Diseases. So,
first of all, I would like to thank you to the organizers of this workshop to invite me and give me the opportunity to talk about the personalization in diagnosis and management of intensive fungal infection. My name is Marija Stošić and I'm an anesthesiologist at Cardiac Surgery University Center of Niš. Why personalization in invasive care, in invasive fungal disease really matters is because it's a combination between the host pathogen, disease site, and drug exposure. Hosts are more likely to be the patient with neutropenia after transplantation, patient in the ICU with abuse of corticosteroids, patient with uncontrolled diabetes, with renal or liver failure. Most common pathogen is Candida, Aspergillus, Mucorales, and some rare molds. Often we can find it in blood, also in lungs, central nervous system, eyes, sinuses, bone, but also can be located in abdominal after abdominal surgery. So personalization means that we need to target antifungal exposure to source control and to do the stewardship. Invasive fungal disease is not only one fungal disease, it's a group of fungal diseases like invasive candidiasis, often found in blostrum or intra-abdominal cavity. We have a high relevance in the ICU. After abdominal surgery with patient with total parenteral nutrition, with central vein catheters, after use of broad spectrum antibiotics. Invasive aspergillosis is mostly found in the lungs, but also we can have numerous infections after viral infection of influenza or COVID-19 in patients with COPD after use of corticosteroids. Mucormycosis and rare mats are rare, as we told, but they are rapidly progressive, has a high mortality, and invasive diseases. So we need to treat and to fight that rare rates and endemic mycosis, and we need to take a good anamnesis for the patient who were on some kind of trips. So for the personal risk categories, we need to make sure that we have some risk phenotypes. So the patient with prolonged neutropenia, we need to do early CT to take some cultures, do the serum, BLA, perform the PCR if it's available, and make sure we don't have some kind of azole resistance. If we have the patient after transplantation, we need to make sure that we consider that the patient may have aspergillosis, rare mats, some candida that are resistant. After solid organ transplantation, it's important to have the site and time after transplantation, and that pathogen is probably depends on the organ that's transplanted. In the non-neuropathic patient in the ICU, we need to make sure we don't have the overdiagnosis of Candida, but make sure to look for the other causes of the infection, such as aspergillosis. We need to use biomarkers to make the decision what kind of infection is it. If we have the patient with diabetes who's not regulated good with ketoacidosis, we can we need to make sure that the patient may have mucormycosis. So the practical frame is pre-testing probability the colleague talked about, that multiplied by performance of the test, and we make sure that the consequences of delay of therapy, which is the consequences of delay of therapy. If we have a low probability, we won't makes that patient receive empiric antifungal medication. If we have intermediate probability, then we will test the patient. But if we have high probability, we will try to we will start to treat that patient and go with the diagnosis, confirming diagnosis. If we have breakthrough while treating the patient, that is always a red flag. If we have a breakthrough when we use fluconazole, we might think that the patient may have some kind of candida species that are resistant, such as glabrata or candida cruzei. If we have breakthrough on the mold active azole, we might think of a resistant aspergillosis. On echinocandida, subkind of resistant candida. When we do the personalization diagnostic personalization, we need to make sure what question we need to answer if we try to rule in the disease or to make the diagnosis. We need to take the sample for the microbiology. We need to take if it's necessary to do the PCR, some kind of tissue or BLA for the culture. If we want to make the de-escalation of the therapy and we want to rule out the disease, then we need to make sure if the single negative test is really excludes the invasive fungal diseases, or we need to have more than one negative test. And we will use more than one negative test to make the de-escalation of the therapy. So in blood culture, most useful is for the candidemia and disseminated yeast, but it has no limitation of invasive for moths and deep candida. BDG we use for intermediate risk candida and aspergillosis, galactomam for aspergillosis, but also we can use PCR. But we need to have the invasive taking of the tissue for that testing. So diagnostic pathways need to be host directed. So if we have neutropenic lung lesion, we need to do early CT. Then to make sure that we perform galactomam in the serum on the BLA. If we have a septic patient in the ICU with high risk candida scores, we need to make sure that the blood culture is that we took the blood cultures, do BDG if it's available in your hospital. If we have synorbital disease with the diabetes, we don't wait for the culture and we treat that patient. If we have solid organ transport pulmonary disease, we need to consider organ type, time from transplant, administration of immunosuppression, and if it's necessary, we need to de-escalate the therapy of immunosuppressors. If we have some central nervous system or ocular symptoms, we need to act immediately. In Candida, where the personalization matters because we first need to know which patient is more likely to get this kind of disease. That's the patient in the ICU after abdominal surgery with total parenteral nutrition, with central vein catheter, after transplantation with renal or liver failure. Most common causes are catheters, intra-abdominal abscess, urinary tract, bone, central nervous system, and the isolate most likely is Candida albicans, but we can have resistant Candidas like Glabrata cruzi. And when we suspect candidemia, we need to obtain two blood cultures before antifungal therapy, if it's possible. First, take the blood sample and then start with the antifungal therapy. Repeat cultures to document clearance and to guide the duration of the therapy. If it is necessary to identify the species, especially if we talk about some resistant Candida species. When we suspect for deep invasive candidiasis, we need to look for the source. It's mostly intra-abdominal collection, some kind of catheter, urinary obstruction, or prosthetic material. Candida therapy, it's important to start on time. When we diagnose the invasive candidiasis, if we have the patient in the septic shock, we will start with echinocandin as early, and it's in every guideline to start with echinocandin. If you have the patient who's after therapy hemodynamically stable with no source of the infection, then you can de-escalate the therapy using fluconazole. it is important to remove the source of the infection. If we have the central vein catheter, we need to remove and replace it. If we have the intra-abdominal candidiasis, we need to drain the collection. We need to control the leak of anastomosis. And if we have some prosthetic or devices infection, we need to consult the surgeon to, if it's possible, to remove that device. Medium candidemia duration is 14 days after documented clearance and symptoms of resolution. So we will de-escalate the therapy and do it for 14 days. For the aspergillosis, we have several severe host phenotypes. Most likely is to be located in the lungs, but we need to make sure that after viral infection, aspergillosis is more likely to find in the ICU in the patient after influenza or COVID-19, in the patient with COPD. So it's important to consider that the patient may have aspergillosis if you have some kind of infection in this patient that doesn't respond to antibiotics. It's important to be personalized by the host and the site where we are going to find the aspergillosis. If we need to perform the chest CT, where we could see the halo sign, cavitation, or array of invasive patterns. We can perform some biomarkers. The colleague already told it. First line is voriconazole, but if we have resistance, we can use liposomal amphotericin B, and if we have very invasive aspergillosis, then we can combine therapy, but it's not in every recommendation. It's important to have the therapeutic drug monitoring while using voriconazole because of his toxicity, and we need to make sure that the patient is receiving adequate dose of the medication, so we won't over or less dose this patient. After clinical stabilization, we may consider de-escalate the therapy for aspergillosis, but the therapy needs to last at least 6 to 12 weeks. For mucormycosis, often we have the patient with uncontrolled diabetes in ketoacidosis, some hematological malignancy after transplantation, after burns, or iron overload, where mostly is located in renal orbital region of the body, rarely in the lungs, or disseminated diseases. When we diagnose mucorales, we need to treat it immediately when we suspect, because it's of his high mortality, and we administered a high dose of liposomal amphotericin B. We need to start, and that's the first line medication. Then we need to remove the cause of the infection, drainage that part, consult the surgeon. After the patient has his hemodynamic stable, we need to think if we may step down for the medication. It's important to repeat and to define the surgical control and exclude progression, central nervous system or major vessels. We need to monitor the renal function and the electrolyte because of administered high dose of amphotericin B. When duration is often prolonged, we need to continue until the clinical resolution, radiological stabilization and improvement, and reversal to the immunosuppressives if the patient was receiving before the infection. For Cryptococcus, it's most likely to be in an HIV positive patient. The syndrome can cause meningitis, pulmonary disease, skin lesions, and we need to make sure that the mortality is high. We can perform the Cryptococcus antigen. In our hospital we don't, but I find that you have the antigen for the Cryptococcus. And if you need to perform the lumbar puncture because of the high intracranial pressure to lower down the pressure, and you can send the liquid for the analysis. We administer a high dose of amphotericin B and flucytosine if it's good for the patient. And for the maintenance of the suppressive therapy in IgV positive patients, we need to low down or stop if it's possible. I said we need to reduce the immunosuppression. So pneumocystis, it's very rare, but it's when we have the HIV positive patient, we have higher organism burden, microscope is more sensitive, and we have some kind of subacute symptoms in these patients. Risk target also is use of steroids after transplantation, during some kind of procedure that requires immunosuppressive. We need to perform chest CT, take the BLA or sputum for the PCR. BDG can also be used. Treatment is mostly like to use trimethoprim sumetaxazole, and if it's possible, clindamycin Primaquine. For the fusarious, we diagnose the patient using culture from the blood, from some changes on the skin, from the BLA, or from the tissue. The treatment is use of voriconazole or liposomal amphotericin B. For the rare mats, it is important to identify and to be able to make the might of the medication that you are giving to the patients. For the Candida auris, it is very rare. We need to have the accurate identification and to suspect for that and to look for it. Then for the initial therapy, we need to make some notes before administering first dose to the patient. In what kind of state is the patient? Is it in shock, hypoxemia? Does he have any kind of symptoms of the central nervous system, rapidly progressive tissue disease? Which pathogen is most likely to be the cause of disease? Candida, Aspergillus, Mucorales. What the patient already received, and can we control the focus? Some central vein catheters, sepsis, some necrotic tissue. So I already talked about the medication we will use in this patient. So echinocandidiasis is first-line medication for Candida. Thiazole we will use for the Aspergillus or step-down Candida options. High dose of liposomal amphotericin B for mucormycosis, and rapid fungal spectrum. If we have some kind of renal hepatic or cardiac problems with the patient, we need to make sure if the patient is having a renal dysfunction that amphotericin B is very nephrotoxic medication. Azole has hepatotoxicity. Most medication works changes the QR parts of the ECG, so we need to monitor that patient in the ICU. So it's important to start smart, to focus fast and finish at the right time. After 48 to 96 hours, we need to repeat blood cultures to the patient to see if the clearance of the fungals, what the cultures, what rapid test we should do or imaging to show, when to repeat it, and are the drug levels that we are administering to the patient good enough. We need to make sure that they are not toxic to our patient, and we need to make sure when to stop, narrow, step down. So that is why this is multidisciplinary model, including clinical physician, microbiologist, radiologist, and pharmacologist. We need to, first of all, take everything together, risk factors, syndrome tests, treat, and when to start the treatment of the patient. So the personalization begins before testing. Diagnoses are most useful when we choose the right tool to diagnose. Initial therapy should match severity and likely pathogen, but definitive therapy should follow species, subspecies, and site and drug exposure. Source control and immune recovery are very important to antifungal intervention, and stewardship is personalized requirement. Start early for high probability patient, narrow quickly when evidence arrives, and stop when probability collapse. Thank you for your attention.
Thank you, Dr. Stošić, for a really nice presentation overview and your experience. So our last speaker in this morning session is Dr. Mia Slade Vitković. She will have presentation online. So she is from Croatia and is a specialist in clinical microbiology. Hi. Affiliated with Department of Clinical Microbiology at the University Hospital Center Zagreb. Her professional work focuses on clinical microbiology, antimicrobial resistance, and diagnostic challenges related to infectious diseases, including fungal infection. She also collaborates with colleagues from the University of Zagreb on several research projects and publications. So her title today is Yeast in Lung Case for Concern, Treatment and Diagnostic Challenges. So Dr. Slade,
Good morning, everyone. My name is Mia Slade Vitković. I work at the University Hospital Center Zagreb in the clinical microbiology department. And today I will be talking about yeast in the lungs, specifically the diagnostic and treatment challenges of yeast lung infection. I will, in this presentation, briefly try to explain the most common types of yeast. They can cause infections affecting the lungs, diagnostic difficulties, and main challenges these infections present. I will also afterwards try to present a case that we had in our hospital to illustrate these issues in practice, and I hope these will provide a complete overview of this topic. I hope that this presentation will provide a better understanding of these sometimes very, very important and often overlooked fungal infections. So thank you, and let's begin. So, yeast fungal infections of the lungs, of the respiratory system, are relatively uncommon in healthy people, but they can become very serious in immunocompromised patients, such as people with HIV, cancer patients, patients receiving chemotherapy, transplant recipients, patients in intensive care units, and they are associated with high mortality rates. In recent years, the incidence of invasive fungal infection has been increasing worldwide. One of the major problems is that fungal lung infections are difficult to diagnose because symptoms are often non-specific. They can resemble other bacterial or viral infections, viral pneumonia, and also treatment can be challenging due to delayed diagnosis, antifungal resistance, or drug toxicity. So because of all of this, early recognition and timely treatment are really extremely important for improving patient outcomes. So although yeast can infect the lungs, they are generally less common than mold-type fungi such as Aspergillus. And one important point in the presence is that the presence of yeast in the lungs does not always mean that there is an active infection. In many cases, it just colonize the respiratory tract and they do not cause disease. So it is important to distinguish colonization from true infection, and this is one of the biggest challenges in yeast lung infections. The distinction is important because overdiagnosis can lead to unnecessary antifungal treatment, exposing patients to drug toxicity, increasing antifungal resistance, and other problems. In the other hand, underdiagnosis may delay life-saving therapy, especially if people are immunocompromised, where these infections can progress very rapidly and eventually be fatal. For this reason, clinicians must always combine clinical findings, imaging, microbiology, patient risk factors before they actually make a diagnosis. So, as I have already emphasized, non-specific symptoms of the yeast lung infections are what makes it a diagnostic challenge. Symptoms strongly overlap with bacterial and viral pneumonia or infections, and patients present with fever, cough, shortness of breath, chest pain, hypoxia. Radiologic findings are not specific. Also, biomarkers are another difficulty. For example, beta-D-glucan can be elevated because not only because of fungal infections, so basically we can have all positive results. So all of these factors make diagnosing yeast fungal infection in the lungs very complex and require multiple diagnostic methods. I think throughout the entire presentation, the emphasis will be on the risk factors of yeast fungal infections, as all of these infections occur within the same subpopulations and have more or less similar risk factors, which will be discussed and have been discussed throughout this presentation. So they occur mainly in immunocompromised with hematologic malignancies, which are a major risk factor. Neutropenia or immune dysfunction are as well a major risk factor. Additional contributing factors would be the use of a broad-spectrum antibiotics, a prolonged intensive care unit stay, as well as invasive procedures done, such as central venous catheters or urinary catheterization. So the most common yeast associated with lung infections are Candida species and Cryptococcus. And Candida albicans is part of the normal human flora and can be found anywhere, basically, in the mouth, the gastrointestinal tract, on the skin. And because of this, it often appears in sputum or other respiratory tract samples without actually causing disease. So in many cases, it represents contamination or colonization, or simple colonization, rather than true lung infections. True pulmonary candidiasis is actually very, very rare. It mainly occurs in critically ill patients that are ICU patients, or in severely immunocompromised individuals, such as transplant recipients or patients with prolonged neutropenia. This is basically the reason that the diagnosis is so very difficult, and clinicians must be very careful not to confuse colonizations with invasive disease. Unlike Candida, which is often only a colonizer, Cryptococcus neoformans is considered a true pathogenic yeast. Infection is usually acquired through inhalation of fungal spores, with the lungs being, of course, the primary site of infection. Clinical presentation can range from practically asymptomatic pulmonary nodules to severe pneumonia, especially in immunocompromised patients. One of the most important characteristics of this fungus is its tendency to disseminate hematogenously, particularly to the central nervous system, where it can cause meningoencephalitis. Because of this neurotropism, cryptococcal infection should always raise concern in patients with HIV infection, transplant patients, or severely immunocompromised individuals. Besides Candida and Cryptococcus, several other yeasts and yeast-like fungi may also involve the lungs, particularly in immunocompromised patients. Although less common, these pathogens are important because they can, as all the others, mimic bacterial pneumonia or invasive mold infection, are often associated with high morbidity and mortality. So recognition depends heavily on clinical suspicion, microbiological identification, and interpretation within the appropriate clinical context. So here I will focus on trichosporon species. Those are opportunistic yeasts like fungi that can be found both in the environment and as part of normal human flora. Humans may be colonized on mucosal surfaces, and the organism can sometimes be detected in stool, sputum, or even hair without causing disease. In immunocompetent individuals, especially in tropical climates, trichosporon more commonly causes superficial infections. However, in immunocompromised patients, it can lead to severe invasive disease, and then it is called invasive trichosporonosis. These infections occur mainly in patients with all of these diseases we constantly talk about: hematologic malignancies, prolonged neutropenia, AIDS, extensive burns, patients on glucocorticoid therapy, and stuff like that. So unfortunately, this disease is associated with very high mortality, and it's often fatal. Most infections begin with the colonization of the mucosal or cutaneous surfaces, particularly when there is a break in the integrity of these barriers. For example, if we have an chemotherapy-induced mucosal damage or the presence of intravascular catheters, once the barrier is disrupted, microorganisms can more easily adhere, colonize, potentially invade deeper tissues. So also, if there is antibiotic use, it increases the incidence and the extent of the colonization because it disrupts the normal microbiota. So it further raises the risk of infections, fungal infections. So Trichosporon osaki is the most clinically relevant species within the genus, and it is a well-known cause of invasive trichosporonosis. These infections are associated with high mortality, particularly in immunocompromised patients. It is often resistant to commonly used antifungal agents, and this is a problem because it significantly limits treatment options. Trichosporon osaki can cause invasive infections, which can be divided into two clinical forms: localized invasive infection and disseminated disease. And the disseminated is, of course, more common in immunocompromised patients and presents typically as an acute febrile illness that progresses rapidly to multi-organ failure. So today, generally diagnostics in the microbiological laboratory have been significantly simplified due to the widespread use of multi-top mass spectrometry and continuously improving reference databases. So basically, as a result, the identification of any species of yeast and trichosporan species, and including trichosporan asahi, have become faster, easier, more reliable, and are allowing rapid and accurate species level identification in routine clinical laboratories, which is, of course, an improvement for the clinical setting. I wanted to present to you a case report that has happened in our hospital in 2022. So this is a report on a patient, a 65-year-old man with a history of B-cell lymphoma, who was in remission at the time of remission. But despite of the remission, I would say that his underlying hematologic disease, his previous immunocompromised state, has remained an important factor in the further clinical course. So the patient has been previously treated for bilateral COVID-19 pneumonia in 2022 in October, and later developed secondary pneumonia and some heart issue, mild heart failure, and due to the deterioration in vital parameters, his clinical deterioration, he was admitted to our hospital to the COVID-19 intensive care unit, and this happened later in November of 2022. So upon admission, he had severe bilateral pneumonia, he was febrile, he was hypertensive, tachycardiac, indicating severe systemic infection, hemodynamic instability. So he also had laboratory findings that showed markedly elevated inflammatory parameters, including CRP and procalcitonin levels, suggesting an severe infectious process. So, of course, the patient had been treated with broad-spectrum antibiotics due to bacterial pneumonia. Of course, remdesivir and corticosteroids for COVID-19 treatment, and of course has been given micafungin, caspofungin, echinocandin to cover candidemia as well. He was mechanically ventilated for 14 days upon admission. So what happened next is that while on this therapy, there was an almost complete regression of bilateral infiltrates, and the patient was removed from mechanical ventilation, was placed on high flow nasal oxygen therapy for respiratory support. So basically, we recorded an improvement. Despite the initial treatment, the patient's condition deteriorated after 7 days of high flow nasal catheter oxygen. support, and he became progressively more dyspnoic with worsening oxygenation and a significant drop in oxygen saturation. So eventually he required mechanical ventilation again. Microbiological analysis of the pleural catheter sample revealed Trichosporin asaki as a potential cause of the patient's clinical deterioration. Subsequent culture of the endotracheal aspirate also isolated Trichosporin asaki, while chest CT imaging demonstrated newly developed multilobular cavitary lesions. In addition, serum beta-glucan levels were elevated, further supporting the presence of an invasive fungal infection. Following the microbiological findings and susceptibility testing, antifungal therapy was modified. Micafungin was discontinued and treatment with isavuconazole was initiated. So, minimal inhibitory concentration testing showed low MIC values for isavuconazole and voriconazole, indicating good antifungal activity, and in contrast, amphotericin B and echinocandins demonstrated significantly higher MIC values, suggesting poor limited therapeutic efficacy. Clinical experience in the treatment of trichosporinosis suggests that patients' outcome often develop more on the condition of the underlying disease and immune status than of the host than on the antifungal agent itself. Among available antifungal therapies, azole agents like fluconazole, itraconazole, posaconazole, voriconazole, isavuconazole have demonstrated activity against trichosporin species. Voriconazole, in combination with amphotericin B, has been most frequently reported in the treatment of invasive infections. Echinocandins are not effective against trichosporin species, which represents an important therapeutic limitations, particularly in critically ill patients that are initially treated empirically with this class of antifungal drugs. So basically, our patient was not covered with the initial antifungal therapy. So why was voriconazole not used? Although voriconazole showed excellent in vitro activity against Trichosporin asaki, it was not selected because of concerns regarding potential hepatotoxicity. So considering the patient's crucial condition, overall clinical status, isavuconazole was considered a safer therapeutic option with a more favorable safety profile. So basically, following the initiation of isavuconazole therapy, beta-glucan measurements showed a steady decline, suggesting that this was a good microbiological response to therapy. Of course, this was accompanied by clinical improvement and stabilization of the patient's condition. So in the further clinical course after initiation of the of antifungal therapy and the decline in fungal markers, microbiological culture of ulcer, the cubitus ulcer, was again positive for Trichosporin asaki, which could suggest dissemination of the disease. But despite of these findings, a follow-up chest CT imaging demonstrated regression of the pulmonary lesions over the following week with further clinical stabilizations over the next 2 weeks. So follow-up chest CT imaging demonstrated regression of pulmonary lesions. At the same time, we had the patient showed gradual respiratory recovery with improvement from mechanical ventilation to high flow nasal oxygenation and eventually conventional nasal oxygen therapy, and microbiological follow-up revealed 2 consecutive negative beta-glucan assays, and Trichosporin asaki was no longer detected in subsequent cultures. In the light of favorable clinical, radiological, and microbiological response, isavuconazole therapy was discontinued. So here, COVID-19 is associated with an increased risk of secondary infections, including invasive fungal infections. Several factors contribute to this susceptibility, such as immune dysregulation caused by the viral infection itself, the use of corticosteroids or other immunosuppressive therapies, prolonged ICU stay, invasive procedures. So basically, COVID-19 is associated with an increased risk of secondary infections. And isavuconazole is a broad-spectrum antifungal with activity against rare but serious opportunistic pathogens such as Trichosporin asaki. And in selected clinical cases, in patients with hematologic malignancies, it has led to clinical improvements and clearance of fungemia even after failure or intolerance of previous antifungal therapies. So successful monotherapy has been reported, but the evidence is limited to case reports, and isavuconazole is actually commonly used as a salvage step-down therapy. So it has a role in invasive fungal infection, but it is still not established as first-line treatment. Trichosporin species, like most other yeasts, can be tricky to. This is what I would like to emphasize, and this is like the course, the core of the presentation, that it can sometimes be very tricky to interpret because the presence of those yeasts in non-sterile sites such as sputum, urine, or mucosal swabs may simply present colonization rather than true infection. So in those cases, we need to correlate the findings and the clinical picture. However, in immunocompromised patients, those who are neutropenic, isolation from a non-sterile site should raise concern, at least. Maybe prompt for further full diagnostic workup. It could be an early sign of invasive disease, but in the other hand, if it is isolated from a sterile body site, it should always be considered as evidence of invasive infection. And blood cultures should frequently be positive in disseminated disease, reflecting hematogenous spread and more advanced infection. So, in conclusion, in this, COVID-19 may act as an additional risk factor for fungal infections, like we had in our case. Isavuconazole shows promising antifungal activity, including in difficult invasive infections such as Trichosporin species, and but further research is needed to determine optimal timing, the exact role, effectiveness, and stuff, and similar questions. So I would like to thank you for your attention.
Thank you very much for your presentation and also for presenting your case. It's very welcome and useful to learn from these cases. We have now time for discussion, for your question, and I would like really to invite all of you to have comments, questions for our speakers, because this is very important part of our course, to share also your experience and now have chance to ask all these nice presenter and so please.
Go ahead. Maybe everything is clear.
No, I think I have a lot of questions here, but I apologize about my English, but I will try to handle some. So I would like ask how important are guidelines in your clinical decision for choosing some tests, microbiological tests, or someone so on. How important are guidelines for this?
In our clinical center, we use the guidelines, and we are constantly in communication with microbiologists. So if we have some kind of test to run or not, but in my clinic, we don't have so much of fungal infection. I work mostly with a bacterial infection because I work on the cardiac surgery, and we don't do the transplantation of the heart in our clinical center. But we use the guides for the antibacterial, for the bacteria, and it's very important.
No, the same question for me. Thank you. As my colleague said, we have a very close cooperation with our hospital microbiologist, and the perks of our hospital that we have a clinical pharmacologist. So in every intensive care units, we use these risks as I shown on presentation, especially candidate score risks. It's simple bedside tool with pointing 1-2 points for assessing patients at high risk. When you have patient at high risk, we usually obtain BDG or we repeat radiography of CT or radiography scans. So when we have a positive BDG that correlates with clinical findings, use of vasopressors, high CRP, high PCT with hemodynamic instability, we often use empirical antifungal therapy until test came positive.
In concrete, do you use PCR for Aspergillus?
No. When we have some suspicions, we cooperate with our microbiology, and that's Dr. Dragana, and she says to us, okay, it's pretty likely that it's something we should do on clinical center, or we should send samples to Patrinok or our laboratory. So it's a multidisciplinary approach, and it's still in developing.
Mm-hmm. If I may ask, which kind of sample you use when you suspect aspergillosis? Sputum or bronchus?
BAL.
Okay. And cytology?
Cytology not as often. As I recall, I cannot recall that we use this cytology.
Also.
So do you have also hematological patient or not?
No, on my clinic. Okay. But while I was working on the clinic for anesthesiology at the general department, we had that kind of thing.
It's easier to do BLA.
Yes.
Because, yeah. You mentioned also Aspergillus resistance. Do you have some Aspergillus resistant to voriconazole in your region?
No, we had Candida resistance but for the Aspergillus, we didn't have. Not the while I was preparing, I contacted our clinical pharmacologist, and she said to me that we didn't have.
This is not from microbiology. We have testing for the susceptibility test for Aspergillus or other ones.
Yeast.
Yes, only
Yes,
yeast.
we do.
Only yeast.
Microbiology.
Yes, because they perform only susceptibility testing for the yeast, not for moths. And for this reason, only ex vivantibus you can decide if this is resistant or not. But there is no laboratory-based test in this region. We perform in my lab, but this is only reference lab in Serbia.
What about Candida parapsilosis? In München this year on ESCMID Congress, there were a lot of lectures about Candida parapsilosis and also resistant. Do you have some problems with this? Because in Slovenia we don't have many kind of.
Also, in my hospital, I cannot recall that I saw positive result for Candida parapsilosis, but there are some changes. Mostly in recent years, it was Candida albicans, but nowadays it's Candida glabrata, cruzae, yeah. So it's that changes in trend. So as bacteria change, fungus change, obviously it's.
But I believe that this depends of the identification type. Now we have here culture-based identification, biochemistry-based identification, but now we have ability to perform proteomic-based identification. And when you use this more precise way of identification, the species diversity could be different. And I don't know in Ljubljana, you use Mathos also. Only Brooker or some, and depends also which platform you use. We can get different results, but okay, this is something challenging.
Mm-hmm. Yes.
Any question from?
Yes. Here.
Yes.
Okay. Thank you very much for your presentation. I am from Spain, from Barcelona. We have a very huge problem of resistant. And we saw that in the last years, the parasitosis is growing, and also the resistance. Fortunately, when you have parasitosis, you don't have calories, so at least you don't have the worst one, but it's growing. Yeah. I would like to ask you, do you have any experience with for the diagnosis of fungal? In our experience, we have very high values, usually in blood samples, above the limit of detection, and very low level would be useful.
May I start with answering? First of all, thank you for coming to Serbia, to Belgrade. I must say that I'm a great fan of Barcelona. I spent a month in hospital clinic in Barcelona. Great to see you here and great to welcome you here. Concerning about your question, as my colleague said, we have BDG sampling from BAL, not intraabdominal sampling, but when I was preparing this and previous presentation about fungal infections, there are so many works about sampling from the intraabdominal sites.
Question from audience, some comments, your experience perhaps.
Okay, then we can discuss during coffee break.
Coffee break. Thank you very much for your attention and enjoy the coffee.
Thank you.
Hvala vam puno na čarovanju. Hvala vam puno. So, short session. Okay.
PowerPoint.
Diagnostic stewardship. Yeah. Are you the first one in your session? Yes. Let's check it. I think as well. Yeah. Perfect. No, no effects yet. Oh, no. Cancel.
There you are.
First one. Let's try.
Okay.
And how we looking at that?
Well, adjust.
Yeah. Thank you.
You can adjust.
Yeah.
Whatever you want. Okay. It's already open, so when you just need to,
Okay. Yeah.
just to click the present button. So.
Thank you.
Ne znam je li ovo nova ili samo sikrana nova, ali korišćena nove zgoda?
Da, i ovo je.
Rekla da u svakom setu ima. Ovdje donese nove čaše. Ne, nema tu jednu. I ovdje.